Our planning and preparation on boosters have propelled a strong start. Just over this past weekend, at pharmacies alone, over 400,000 Americans received the additional protection of a booster. And almost 1 million people have already scheduled their booster shots through pharmacies over the coming weeks.
The U.S. has opened up those third COVID shots, those boosters, to millions of Americans. Canada has started to do the same, though it's only recommended for long-term care residents at this stage. Dr. Scott Gottlieb is the former head of the U.S. Food and Drug Administration. He says data out of Israel could support those as young as 50 benefiting from the Pfizer-BioNTech booster. Dr. Gottlieb has a book out this month, Uncontrolled Spread: Why COVID-19 Crushed Us and How We Can Defeat the Next Pandemic. Dr. Gottlieb is currently a member of Pfizer's board of directors. He is in Westport, Connecticut. Dr. Gottlieb, thank you very much for taking some time. And I do want to get to your book, but I'm also starting on a day in which Canada's advisory panel on vaccines is recommending booster shots, third shots in the case of this country, for those who live in long-term care and congregate care settings. Now, there's been some dispute between various panels around the world, including in your own country, in the United States, about whether booster shots are absolutely necessary. You sit on the board at Pfizer. How do you see it?
Well, look, I think the data coming out of Israel and the UK shows that there's groups of patients who can clearly benefit from booster shots. Here in the United States, there's a broad recommendation that those over the age of 65 and who live in long-term care facilities should go get booster shots. That's based on data that shows declining vaccine effectiveness over time in older individuals who were vaccinated a long interval ago. So it's mostly relying on data out of Israel, where you have a lot of people who were vaccinated 8-9 months ago, where you see declining vaccine effectiveness, more breakthrough infections, and rising incidences of more severe infections in that cohort. For people under the age of 65, the data is a little less clear. Here in the United States, we're recommending boosters for people who have medical conditions that put them at higher risk of a bad outcome from COVID, and also those who work in occupations where they're more likely to come into contact with COVID and contract the disease. I think the data out of Israel could support booster shots for those over the age of 60, and maybe even you can make a case for those as young as 50. But here in the United States, we used 65 as a cutoff where people should go get boosters.
Now, I want to talk about kids, but before I get there, I'll stick with the general population and talk about what you have talked about before, that if new mutations occur that do escape or partially escape vaccine immunity, then it would be likely in the Delta lineage. Are we likely to get to a point where there has to be a new formulation, say, every year, and we have to get a jab every year to be up to snuff, essentially, against COVID?
Yeah, look, I think it's hard to tell, right? We don't know how durable the immunity is going to be, especially after a third dose. But I think the conventional wisdom is, at least for the foreseeable future, this is likely to be an annualized vaccine, and we're likely to reformulate this vaccine over time, perhaps not every year, but maybe every couple of years. My hunch is, based on my general understanding, that the reformulation of a vaccine, if we do end up reformulating it, the conventional wisdom when you talk to the genetic epidemiologists is that we're likely to reformulate the vaccines based on a Delta backbone, so that if there are new mutations that partially escape the immunity offered by the current vaccines and offered by previous infection, they're likely to occur within the Delta lineage. So some subgroup of Delta will emerge that partially evades the immunity that we've acquired. And there's actually 20 different variants of Delta. So Delta is already mutating. So it might be the case that next year we use Delta as a backbone. Final point, we really haven't started an international process for making that determination of when we will switch over the vaccines. It's very well regimented for how we make determinations about the flu vaccine, what the backbone of the flu vaccine is each year, but we haven't determined yet what that process is going to be for the coronavirus vaccine.
I want to talk to you about kids because regardless of what side of the border we're on, we see a lot of the new infections are happening in younger people, particularly those under the age of 20. But of course, those under the age of 12 are not able to get the vaccine, not yet authorized. We do see today, though, that Pfizer-BioNTech has submitted its initial trial data to the FDA in the United States for those kids aged 5 to 11. That has not yet happened with Health Canada. Do you have a sense of that kind of timeline?
I don't have a sense of the timeline outside the United States. In the United States, the data was submitted today. That starts a rolling submission and puts it on a time frame where you could have an authorization here in the United States for kids aged 5 to 12 or 5 through 11 as early as Halloween. If it gets pushed a little bit, maybe into mid-November, obviously subject to the FDA's review and their agreement that the data supports that authorization.
So let me look at what vaccine that you then use, because we got a whole bunch of vaccine that are sitting on shelves here, but I understand we wouldn't be able to use those vaccines even in smaller quantities for kids. Why is that?
Well, the vaccines that are being tested in children are lower doses because you want to find an optimal dose where you have an equivalent amount of antibodies produced by the vaccine. So you have an equivalent immune response, but you minimize any vaccine-related side effects, any kinds of immediate reactogenicity, things like fevers and injection site reactions. And so you're trying to test the lowest dose possible that's going to elicit an appropriate immune response. And Pfizer actually tested 3 different doses in children aged 5 to 11 and chose the lowest dose because it produced a comparable level of immune activity that you saw in the 16 to 25-year-olds. Obviously, with a lower dose, you get less reactogenicity.
Okay, and forgive my ignorance on this, but we got 18 million doses sitting on the shelves. So it's not like you could just literally take less out of a vial and inject it into somebody. It actually has to be completely reformulated. In other words, Canada would have to order a whole bunch of new vaccines?
Well, actually, it's the same exact vaccine, same formulation, just a lower dose. But subject to public health authorities, a lot of public health authorities won't want you going into those vials more than a certain number of times. So if you have a vial that's used for dispensing 30 micrograms and now you're dispensing 10 micrograms, you're pulling out a smaller amount each time you go in. So you're going in and out of a vial with a needle multiple times, more times, and that introduces the risk that you could introduce bacteria into the vial. So typically you'd want to introduce vials that have lower quantities of the vaccine in it so that you're not going into it as much. So in the United States, we're actually preparing different vials for the children, but it's the same exact vaccine, same formulation, just a lower dose.
In your book, you talk about the failures by some agencies in the United States, including the Centers for Disease Control. In those initial days, it took CDC 46 days to get to the point of having a working test. Apart from, the limitations, the fact that having such a delay on those tests obviously had impacts on accurate testing. How detrimental do you think this was in the overall fight against the pandemic, particularly in those early days and where we find ourselves now?
Yeah, look, not having diagnostic testing at the outset, I think, set us back tremendously. And it was a symptom of a larger disease in terms of our agencies not being prepared for a public health disaster of this magnitude. We really didn't have an agency capable of mounting the kind of logistical response we needed, developing and mass deploying a diagnostic test and setting up the testing centers. Because we didn't have a test, we couldn't monitor the early spread in the United States, so we were heavily seeded with infection and didn't know it. And then once we discovered that there was a lot of infection underway, we didn't have a diagnostic test to tell us not only where the virus was, but where it wasn't. So when we had to reach for mitigation, population-wide measures to try to control the spread, asking people to stay home, closing schools, rather than targeting that in areas where we knew the virus was spreading, we did it nationwide because we didn't know where the virus wasn't spreading. And what happened was we ended up shutting down parts of the country where the virus hadn't arrived yet. And then when the virus finally arrived in those parts of the country, like the South, people said, look, we're not shutting down again. We did this in the spring when we didn't have to. The virus wasn't here yet. You told us we had to, and we're not doing it again. So you ended up losing the political capital to target the mitigation once the virus arrived in different parts of the country. Was it managed politically well? I think there were a lot of political mistakes made in leadership. It wasn't just at the White House level, but also at an agency level at the Department of Health and Human Services. Early on, you needed to get the diagnostic manufacturers into the game. Someone needed to make a phone call in January to the big diagnostic manufacturers and say, hey, we're concerned about this virus spreading in China right now. We want you to start mass manufacturing diagnostic tests. There's a 4 to 6 week lead time to do that. Those phone calls weren't really made till the end of February, so we never had enough testing in the early throes of this virus. Speaking of phone calls that weren't made, still a lot of criticism and concern about how little was known in those early days, how much was communicated from China, but also how little we know right now, still to this day, about the origins of this vaccine. What do you think countries like the US and Canada need to do to get better at detection for whenever the next one comes? Yeah, and I talk about this a lot in the book. I talk about, in the case of SARS-1, we didn't discover that SARS-1 was spreading in China until some infections arrived in Canada, in Toronto, and Canadian physicians sequenced it for the first time, discovered it was a novel coronavirus. And that's, in fact, when the Chinese government disclosed that it was a novel coronavirus. Up until that point, they said it was a fungus that was infecting people, and they disclosed the full number of cases that were underway. I don't think we can trust countries anymore to be forthcoming about these emerging infections, especially countries that we don't have close relationships with. And I think we're going to need to get our national intelligence tools more engaged, our overseas operators, agencies like the CIA and the NSA here in the United States, intelligence agencies, to actually monitor potential hotspots to try to detect when these new infections emerge. Up until this point, we've relied on multilateral agreements between countries and public health officials working together. But what we've seen time and time again is countries aren't forthcoming with this information. And finally, if anything, COVID has conditioned countries to be even less forthcoming, because what's the first thing that happened when the British disclosed that they had B.1.1.7, a contagious new variant? The French closed the channel. So if anything, we've normalized trade and travel restrictions as a way to try to contain outbreaks, and that's going to make countries even more reluctant to share this information. So we've got to develop the tools to gather this information, not just rely on the good graces of other nations to inform us when these outbreaks occur.
Dr. Gottlieb, thank you so much. Appreciate it.
Thanks a lot.
Hi, I'm Vashi Capellos, host of Power in Politics. See more of our show by subscribing to the CBC News channel or click the link for another video.